Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Hello again, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and I am glad to have, this is number 5, Doctor. I didn't bring any gold stickers. Again, I should have.
That's it. I'm walking out.
Well, I should get you a jacket with like a gold star on the back. Would that work?
Perfect.
Kind of your own.
Perfect.
A pediatric critical care doctor and pediatrician, Dr. Kyle Lemley, is with us. And joining him again is Amy Morrill, nurse educator, and Amanda Horsley, the nurse manager from Monument Health. You guys work together as a team to make sure that our kids in our area are going to be taken care of, right? 100%. For sure.
Absolutely.
And today, thing is, Doctor, we have teased this so much that I can't wait for the day we finally get to unveil all of this cool stuff that's coming to Monument. But we will very soon. But what we do get to talk about in this episode is what is known as the PICU. Correct? We can finally call it.
We can call it
the
a PICU.
Now, really quickly, define what this is, Doctor.
So it's a pediatric intensive care unit.
Okay.
So just like you have an adult intensive care unit or the neonatal intensive care unit, everyone's kind of familiar
the NICU,
with.
Yeah.
Yep. So this is the ICU in between those two. So once you get sent home from the hospital from being a newborn up until you're 18 years old, if you need intensive care, you come to see me in the pediatric ICU.
Okay.
So we can do everything, from severe sepsis, severe infections, having significant blood pressure issues, needing different modes of ventilator or breathing machines. Really, we can do most anything that they can do any other place. And so we already don't have to transfer a lot of kids out of the area because we can now provide that level of care.
And that's why this was a big deal.
Huge deal.
Yeah. But why couldn't we call it a PICU? Up until whatever. What are the reasons for that? Can you go into that at all?
Just high level. I don't even know that I truly understand why we did a lot of regulatory things.
Is that
going
what
on.
it is? That
so
makes
we didn't
sense.
have boxes checked in our regulatory documents that were released to different governing bodies.
For it to be called this checklist of things had to be done.
Right. One, it helped that we actually had pediatric intensive care doctors, so physicians that did an extra 3 years of training just in the pediatric ICU. And then making sure that we had documented that you could get in touch with us within 5 minutes or something. And that we had a 20-minute response time and several other just random boxes to check that people weren't aware that we were already checking those boxes.
Yeah.
Just once you get pediatric critical care physicians here, there's an expectation from us of you have to get in touch with us.
Yeah.
We need to be available. Like that.
Right.
Just come with the job.
Okay. Now, speaking of, and before we started this podcast, I had asked you, Amanda and Amy, about the difference between a PICU and a NICU.
Yes.
And I guess if you think about it for a minute, you should be able to figure it out. I didn't figure it out. So what's the difference between the two?
Great question. Nothing, we give you grace, don't you worry. Our neonatal intensive care unit is for babies who are born either sick or too early. So those babies can sometimes spend months in our NICU with those nurses taking care of them until they're big enough and healthy enough to go home. Once they go home, or once any baby goes home, if they end up needing to come back to the hospital, they'll come to either our pediatric unit or our pediatric intensive care unit, our PICU, depending on how sick they are and what level of care they need.
So that's the difference. If you're born with the sickness, NICU. If you're born and come back, PICU.
Absolutely.
Best names. We're
not really that smart.
No,
you have to name it obvious thing.
Right, but that sticks with people then. I mean, everybody knows what a NICU is, even though I bet you couldn't ask a lot of people what does it stand for.
Right.
But they know exactly what it is. Are there things about working in the PICU, the Pediatric Intensive Care Unit, that people might not expect? in your line of work?
Absolutely. I think for me, the biggest surprise is just the miracles that we get to see. Kids are very resilient, and they can come back from some pretty traumatic events. And we are always just amazed at how great they do, how eager they are to do their therapies, how well they respond, and how well they heal. And so we just get to see miracles every day, and it's such a blessing.
Oh, that would be. I mean, it would be hard though too, wouldn't it? You see them coming in at their absolute worst, and you got to wait that amount of time to hopefully see that miracle that you're talking about for sure. Is that the same for you, Amy?
Yes. It truly is amazing to see what they look like coming in and then walking them out to their car to go home. I love seeing miracles, and I've been lucky to see quite a few in my time. Or see how we can support the family when things don't always go the best way, and how we can stay connected to those families to help them push through.
Okay. Well, Doctor, what's your role specifically within a PICU then, for in this whole new arena?
Yeah. So I manage the majority of the patients that come into the pediatric ICU. So I'm the primary attending. I always talk about I'm a big generalist. So I always talk about that all the physicians, we all have a box that we stay in. My wife is one of the pediatric hospitalists here. She's the only one that's currently full-time.
Now, what is that? What is it? I've heard the term hospitalist before.
Yeah, so a pediatric hospitalist is a pediatrician that may or may not have gone through extra training to just work in the hospital.
Oh,
and so any kid that needs to be admitted to the pediatric floor, we have a team of pediatric hospitalists that they manage those kids. And so they take care of them if they're not super sick. But if they're really sick and needing more care, they come back to me. And so my box just happens to be bigger than a lot of people's boxes.
Yeah.
And the lung doctors have their box, and the kidney doctors have their box, and the heart doctors have their box. And my box extends further into their boxes than what a hospitalist does. The hospitalist team, they can dabble in some of those boxes a little bit more than others. But my role is my box encompasses their box a lot more.
So are you involved with the NICU too? Are you involved in that? Or is that a whole separate thing?
Whole separate team.
Okay.
There's neonatologists that they do a whole neonatal perinatal fellowship. And so they do 3 extra years in just the NICU. And so they do their own thing. We cross over on when kids get too old to be in the NICU, where they kind of outgrow the NICU, but they still aren't ready to go home. They'll come up to the PICU, so we'll cross in those worlds. And then, and especially in larger institutions where you do pediatric heart surgery and that kind of stuff, our worlds cross a lot because they are initially in the NICU, but then once they get ready to go to surgery, they either come to the PICU before surgery or right after surgery. And so then we kind of cross a lot on some of those kids. But here, predominantly once they get too old, they come to see us in the PICU. But my role is just taking care of the kids that are super sick, figuring out why their body is reacting the way that it is, why it's so sick, what I need to do to get their body back in kind of normal working order, if you will, do what we can do to get them there. And then once they don't need the ICU anymore, then I just send them over to the peds floor and let them kind of finish tidying things up. Sometimes all I can do is figure out enough to get them stable and through the super sick part. And then they need a lot more testing and kind of more general pediatrician kind of thoughts. Right. And so then it's nice to be able to send them over to the floor and be like, tag, you're it. And I get to move on to the next sick kid.
That's okay. That makes perfect sense. Explain that very well. Now, here's my really dumb question.
No dumb question.
Wow.
Maybe
there can be. Don't worry.
I'm ready to be shot.
There can be that much change from a newborn to somebody that's 5 years old, 6 years old, 7 years old, that you need 2 different specialists to work with them in I thought our bodies were our bodies. I mean, I know they grow at some point, but
So when babies are born premature, none of the organs are functioning the way that they were designed to function necessarily when you reach full term. So those doctors really have to take care of the lungs very carefully to help what alveoli or air sacs are formed to help not damage them further. Make sure that they're feeding them appropriately, but not too much, because you can cause damage to the gut by being too aggressive with feeds. And so they're their own world. Like neonatologists, they have the option of every neonatologist went through a pediatric residency. So every neonatologist at one point in time was board certified pediatrician. But because neonatology is so super specialized, they can get rid of their pediatric board specialty and not worry about it. I don't have that option because mine's so integrated with general pediatrics that, so yes, they are their own super specialized group. My wife and I joke that, like, unless you need to be intubated or have tubes put in you or something, like, you probably don't want me taking care of you, because I've gotten that specialized that when you just need general ped stuff, go to the floor.
Right.
Have the floor pediatricians take care of you, because they are much better at just normal.
Yeah, you are one of those
stuff.
doctors where
You don't want to see me.
parents don't know. They don't want to see you at all.
Nope. But when they need to, we're here for them.
So glad. How many doctors are there like you here at Monument? Is there just you?
Me.
Is it really?
We have locums that come in and cover me. And we're interviewing someone tomorrow that I really like, and hopefully he'll decide to join us. And
well, that's the goal for this too, isn't it, though, is to grow this.
Right.
To make sure that, we've got it here in our community.
Yep. The goal is to have a fully staffed pediatric hospitalist and pediatric ICU team.
So what's your day like then? I mean, when you get up in the morning, what time are you at work and what time do you get to go home? Does it vary quite a bit?
So we do 24-hour shifts, and I usually do a minimum of 6 to 7 in a row. And so it just depends. Some days we start rounds at 9.
Yeah.
Some days I come in at 8:45 and I'm ready to start rounds. Other days I came in at 12:30 at night because there was a super sick kid that needed to be admitted, and I may or may not have slept additional, and then do rounds and then go take a nap. But I take naps when I can during the day, whenever I'm on, or at night. The nurses are great. They call me when they need to call me. But they also don't call me with the little things that I don't need to know about until, I check in again. That
takes a whole other specialty, just to be able to nap at any time, too. You got to take it whenever you can in a lot of instances. Well, I'm sure you get to a point where you're just exhausted, though, too, aren't you? For sure?
Yeah. You definitely get to that point. And then we talked about the sedation in a different episode, but the sedation days start about 6:30, 6:45 in the morning. And so then if I'm in the ICU that day too, then juggling both of those at the same time and stuff. So
well, I'm sure I asked you this the very first time we talked, but what drew you to this? Why did you decide to make this your specialty?
I don't think I was thinking at the time. No.
Did you know you always wanted to be a doctor?
I wanted to be a doctor ever since I was 6.
Okay.
My dad's a nurse anesthetist, so it puts
in the
people
family
to sleep. Yep. My mom was an RN in surgery for years and years, and I actually had a birthmark taken off when I was 6, and decided for some reason then that
I could have done it.
I wanted to be a doctor, and so initially I wanted to go into surgery, and then we started having kids in medical school. Mm-hmm. And I didn't want to spend the time away from my kids that you have to do in surgery. In surgery, you're doing 100+ hours a week and all of that kind of stuff. And that wasn't going to work well for us. And I helped resuscitate a 27-weeker when I was in medical school. And so with that, I went to Tamara, and I was like, I think I want to switch to peds. And she was like, I'm not buying it. You still want to do surgery? And I was like, okay. So then we figured out if I got stuck in just a clinic for the rest of my life, because we snow ski and like to go whitewater rafting and different stuff where you could easily hurt yourself, so you couldn't be a surgeon. So if I got stuck in a regular clinic for the rest of my life, what clinic would I like most? And pediatrics was by far the one clinic that I enjoyed more than others. And so then we decided it was okay to switch over, but switch to pediatrics to do neonatology. And then in residency, I was talking with one of my mentors / friends, and she was like, you have to decide, you have to go into what you want to read about for the rest of your life. And so for neonatology, the bread and butter is feeders and growers. So the kids that really aren't that sick, but can't figure out how to suck, swallow, and breathe at the same time. And so they just need to be in the NICU until they can figure that process out. And I hate reading about nutrition versus love reading about asthma and DKA and sepsis and all of these other things. And so when I kind of step back and go, what do I like to read about? I like to read about PICU more than NICU. And so decided to do pediatric critical care, and here I am.
Well, I imagine the juice boxes are so much better too.
Oh,
I mean,
there's chocolate milk in the fridge. It's so
all the
good.
time.
All the time.
Well,
and ice cream.
How did you guys get? Is it kind of the same with you guys? Did you always want to work with kids, or?
My path was a little different. I actually started in surgery as a circulator nurse, working with the cardiovascular team.
See, it was close. I
It was close.
I was a script tech all the way through college.
Oh, well,
so.
we could have done it. We have more fun now, though. And then I realized I love trauma. I love the adrenaline rush, and I worked in the emergency department for a little while. And then I luckily had NICU babies of my own. Oh. And so that threw my world all the way around. Mm-hmm. And so they were 24-week triplets, and went through that very traumatic situation for months and realized my heart was with kids, and I feel like I'm meant to be with kids and to help families go through very serious things for their kids. And so I jumped and I landed in pediatrics, and I'm so happy.
You're not looking back.
Nope.
That's awesome. What about you, Amanda?
I, like Dr. Lemley, knew that I wanted to be in the medical field my whole life, but I never thought I wanted peds. That was a fun surprise for me. I had some really great clinical experiences while I was in nursing school on our pediatric unit, and just never looked back. It's all I've ever done. It's where my heart is, and I couldn't see myself anywhere else.
You know, just listening to the three of you describe it, I love to hear what you've said, because you can hear that all three of you genuinely care about this, right? And what else could you want when your kid is sick? Because we've all had the sick kids, you know, and if we can come see the three of you, that makes this so much better. You know, and it's we talked a little bit about in the sedation episode that we had with you guys, you know, about how you make kids feel comfortable, how you make parents feel comfortable. Is there, if you guys could make a wish for one thing that would solve a lot of these challenges you guys have in pediatric intensive care, what would it be?
My wish would be to get rid of the chronically ill kids that are on devices to just live, whether it's feeding tubes or a tracheostomy or a tube in their neck so they can be hooked up to a ventilator. And have the ventilator breathe with them or for them, kind of depending on the kid. But if I could get rid of the chronically ill kids that are dependent upon equipment to live, I would get rid of that.
That'd be the big one.
Yeah.
Oh, that makes perfect sense.
You would heal them all.
I would.
Well, that's kind of why you're doing this for sure.
Dear Santa, I have not been good this year.
But that doesn't matter.
But please.
Right.
Please heal the kids.
Do you guys see exciting things on the horizon that might lead to changes like this, that might lead to things that are, you know, because we've talked about the medical field and how quick it changes. There's very few professions where I think things move as quick as they do in this field, right? Outside of tech, you know, medical is amazing how quick everything changes. Do you guys see exciting things on the horizons for kids and parents? Anything specific, maybe?
Well,
I think there's exciting things. There's always different modes of ventilation that's coming out so that we can, when kids need to be intubated or be put on a breathing machine, we can be more gentle with the lungs and that kind of stuff. There's more and more data coming out on how to manage these kids better and safer and everything. But honestly, for my wish, the NICU keeps getting better and better at the kids that they can save. And so as they get younger and younger on the kids that they are able to save, that means that there's a higher and higher risk of those kids having complex medical issues.
Right.
And so I don't see the complex medical kids going away. If anything, we've seen more and more complex medical kids. Even I started fellowship in 2012 and finished in 2015, and there was an increase in the number of chronic kids we had in the ICU in that just 3 years of it. And so I think there's advances in the PICU, but advances in the NICU are keeping us with more complex kids from time to time.
Boy, that's something that never would have crossed your mind. Better at saving these kids at younger and younger pre-birth. Mm-hmm. But yes, most of them will end up with complications down the road. Yeah. Some of them, right? And so you guys are really needed more now than ever before, which is good and bad, I guess, in kind of a way, isn't it?
Yeah, kind of going to Amy's comments on the ER of how it used to be super acute things, and now it's ER is primary care on speed, mm-hmm. and the ER doctors don't get to do nearly as much fun things as they used to do, right?
Right.
Oh, you trauma doctors and nurses, you guys, seriously, just get a motorcycle and go, all right?
Skydiving didn't have enough adrenaline for me.
Oh, you guys are amazing in your desire to want to do and see those sorts of things. So when kids are coming in and parents are coming in and what's the one thing that you always try to reassure them when they're there? Is there a standard that you guys go to that you say, look, everything's going to be okay? I mean, you want to say everything's going to be okay. Sometimes you know that, but I mean, how do you guys handle that? What do you do in those situations? How do you make sure that if I'm coming in with my sick kid, I'm going to feel comfortable with you guys?
For me,
at the end of the day,
I always say what Einstein used to say of, if you can't explain it to a 6-year-old, you don't really know what you're talking about. So being able to just tell you what's going on in a way that you can understand it is the thing that I can do, I think, the most. 1. 2, unfortunately, I'm not the guy you want to ask if everything's going to be okay, because if you're in my unit, there's a risk that it's not going to be okay.
Right.
And for me, I honestly tell every patient, or most every patient, that ultimately I believe there's one true physician and he's in charge and I'm not him.
Right.
And so just knowing that, really we're doing the best that we can, but ultimately we don't have ultimate control over what's going to happen.
Right, exactly. And, well, you guys talk with the parents quite a bit. I'm assuming you're their first line, aren't you?
Right. I would say that's the biggest thing, is that we keep the family well informed of what the plan is going to be, and set small goals. Okay, this is our goal for the next hour. This is our goal for the next 2 hours, and set just minimal things that we can work towards, because I always think you need to have a little bit of hope to try and get towards something in those critical states, whatever the case may be. And so we're working with the family, working with the support people that they have, and then just doing what you can. Kids are amazing, and kids are resilient. You really never know. And so putting a spin on something for that child to get them to respond a little differently sometimes can be a big game changer.
Oh, that's amazing. You guys, I want to have you come back and talk about more stuff someday. So whatever. All three of you come in and let's do this again. All right. Dr. Kyle Lemley is a pediatric critical care specialist and pediatrician. Amy Morrill is a nurse educator. And Amanda Horsley, I won't say it again, but the nurse manager. Okay. Anyway, you guys, thank you for coming in and talking about this. And I know that throughout, I'm assuming in 2025, there's going to be even more big fun things we get to talk about for sure that are going to make Rapid City, the community itself, breathe a huge sigh of relief, I think. Is that fair to say? Did I oversell it a little bit?
That's the hope.
Okay, good. All right, then that's what we're going to do. So thank you guys for coming in. I appreciate it, and hopefully we'll talk to you next spring and summer, and we'll have even more fun things to say.
Sounds
Mark.
good.
Thank you.
Thanks, Mark.